Assalamu alaikum. Good morning. Today we are going to discuss principles of non-surgical treatment for cancer. In contrast to surgery, it is possible to construct dose-response relationship for both the benefits and harms associated with non-surgical intervention. Treatment must be delivered in such a way as to ensure that the damage done to the tumor is more than the damage done to the normal tissues. Curative surgery for cancer is guided by one simple principle, that is, physical removal of all identifiable disease. The principle underlying the non-surgical management of cancer are more complex. That first, the spatial distribution of treatment must be considered. Is surgery and radiotherapy, that of course would be for local treatment, or at best locoregional treatment. Drugs in the form of chemotherapy or hormonal therapy would be more effective as compared to surgery alone or in combination of radiotherapy. Now we briefly talk about radiotherapy. Within a month of their discovery in 1895, X-rays were being used to treat cancer. Until about 30 years ago, it was assumed that biological effect of radiation resulting from radiation-induced damage to the DNA of dividing cells. Radiation can both directly and indirectly influence gene expression, and by now over 100 radiation-inducible effects on gene expression have now been described. In this sense, radiotherapy is a precisely targeted form of gene therapy for cancer. If we just talk about the practicalities of radiation therapy, there would be mainly three things we just need to consider. The first thing is defining the target. That must be the subject of treatment. And for that, one must have a good knowledge of anatomy, pattern and probability of spread of disease must be known to that person. Cross-sectional imaging in the form of CT scan, MR, or even functional imaging with help of PET scan or functional MRI might be required, and most of the time they do required. The second thing is designing the optimal technical setup to provide uniform irradiation to that target area. And number three, to choose that schedule of treatment that delivers radiation to that target so as to maximize the therapeutic ratio. And optimizing the therapeutic ratio would be to choose that combination of total dose and number of treatment, that would be fraction, and overall treatment time, so that the damage to normal tissue is minimized and the effect on tumor are maximized. Typically, the application of radiotherapy are being discussed or elaborated by 5 hours. Initially, it was 4 hours for radiotherapy, but subsequently, the 5th hour, that was intrinsic radiosensitivity, was added to it. The first of it is repair. If given sufficient time between fractional doses of radiation, cell will repair the radiation induced damage, and the repair half-life would be around 3 to 6 hours. Reoxygenation is the second one. From our previous lectures, we know that the tumor cell, they are relatively in a state of hypoxia. For radiotherapy, the more the cell they are well oxygenated, they are more radiosensitive. So by default, the tumor cells are a bit radio resistance. So that's an obvious therapeutic disadvantage. Repopulation. As radiotherapy kills cancer cells within a tumor, it may provide a stimulus to rapid growth and proliferation of tumor cells. That would be known as repopulation. The fourth thing is redistribution. The sensitivity of cells varies along different cell cycles. Ideally, the radiotherapy should be fractioned in such a way that it should coincide with the vulnerable phase of the cells, that is late G2 and M phase, in a particular synchronized population of tumor cells to have maximum effect. Radiosensitivity is the fifth one. The tumor cells have a variety of radiosensitivity and radioresistance. There are two extremes. One, they are radioresistant, and the other one who are extremely radiosensitive. Luckily, most of the cells, they fall in between these two extreme range. Now we'll talk about chemotherapy and biological therapy. Selective toxicity is the fundamental principle underlying the use of chemotherapy in clinical practice. Chemotherapy by itself rarely is sufficient to cure cancer. Over 1 million different drugs licensed by the US Food and Drug Administration for the treatment of cancer has been approved. 30 of them were approved between 2013 and 2015. Majority of the drugs are cytotoxic drugs. That's around 65%. And hormonal therapies account for around 10%. An increasing number have been designed to interact with specific molecular targets, so that is specifically called as targeted therapies. In patients with documented distant metastatic disease, chemotherapy is usually the primary modality of therapy. The goal of therapy in this setting is to decrease the tumor burden, thus prolonging survival. It is rare to achieve cure with chemotherapy for metastatic disease for most solid tumors. Though chemotherapy administered to the patient who is at high risk of distant recurrence but has no evidence of distant disease is referred to as adjuvant therapy. That would be done either postoperatively, thus would be known as postoperative chemotherapy or adjuvant chemotherapy, or given before surgery, that would be known as preoperative chemotherapy or neoadjuvant therapy, or even known as induction therapy. So what would be the advantages of chemotherapy given preoperatively? First, preoperative regression of tumor can facilitate resection of tumor that were initially inoperable, or allow more conservative surgery for patients whose cancer was operable to begin with. Second, treatment of micrometastasis without the delay of postoperative recovery. Third, ability to assess a cancer response to treatment clinically after a number of courses of chemotherapy, and pathologically after surgical resection. Chemotherapy destroys cells by first order kinetics, which mean that with the administration of a drug, a constant percentage of cells is killed, not a constant number of cells. Chemotherapeutic agents can be classified according to the phase of the cells during which they are effective. There would be phase non-specific agent or phase specific agents. Phase non-specific agent, for example, alkylating agents, have a higher linear dose response curve such that the fraction of cells killed increase with the dose of the drug. and phase-specific drugs have a plateau with respect to cell killing ability, and cell kill will not increase with further increase in drug dose. If you just talk about alkylating agents, they are cell cycle non-specific agents. They act by cross linkage the two strands of the DNA helix or by causing other direct damage to the DNA. The damage to the DNA prevents cell division and, if severe enough, lead to apoptosis. Examples are cyclophosphamide, mitomycin C. There are certain antibiotics, like they are the product of fermentation of microbial organisms. These agents are cell cycle non-specific. Anti-tumor antibiotics damage the cell by interfering with DNA or RNA synthesis, although the exact mechanism of action may differ by different agents. The next category is anti-metabolites. These are cell cycle specific agents that have their major activity during the S phase of the cell cycle and have little effect on cell in G0. They interfered with normal synthesis of nucleic acid by substituting for purine or pyrimidine in the metabolic pathway to inhibit critical enzyme in nucleic acid synthesis. Examples are methotrexate and azathioprine. There are certain plant alkaloids that are being used as anti-cancer agents. These are derived from plants such as periwinkle plant, Vinca rosea, or the roots of American Mandrake podophyllum plants. And examples are etoposide or podophylltoxin. While Vinca alkaloid affect the cell by binding to tubulin in the S phase, this block microtubule polymerization, which result in impaired mitotic spindle formation in the M phase. Examples are vinblastine, vincristine. Now we just talk about combination therapy. In cancer chemotherapy, mostly we use drug in combination, not as a single agent, because the rationale behind combination therapy is to decrease drug resistance and having a combination effect as synergistic effect. There are three main principles upon which choices of combination therapy is based upon. Number one is drugs used should be effective against the disease in question. They have distinct and different mode of actions. Use drugs with non-overlapping toxicities. In considering the combination of radiotherapy and chemotherapy, radiation could be considered as just another drug. In case with the disease is advanced and it won't be a curative one, then palliative surgery or palliative therapy would be the main subject. These days, a distinction between palliative and curative treatment is not always clear cut and will become increasingly blurred as professional and public attitude toward the management of cancer changes. 20 years ago, it was perceived as a disease that either the cancer could be cured or it's not. Simply, the patient can live or he will die. There was little appreciation that for many patients, cancer might be a chronic disease. Nowadays, it is appreciated that many of the so-called curative treatment are simply elegant exercise in growth delay. The aim of the treatment will be growth control rather than extirpation of every last cancer cell. Patient will live with the cancer perhaps for years. They will die with cancer, but not necessarily because of cancer. So, the control and relief of symptom is crucial to successfully manage a patient with cancer. And most of the patient with advanced cancer or with the chronic cancer, they would need definitely some symptomatic relief, psychological intervention and support, physical and practical support. They need information and knowledge regarding their disease and nutritional support as well. Social support would be required by the family and by the healthcare provider. Financial support might be required, and of course, according to their belief and the religion, spiritual support would also have definitive effect. Now we just briefly talk about end-of-life care. End-of-life care is distinct from palliative care. Patient treated palliatively may survive for many years, while end-of-life care concern for the last few months of a patient's life. Many issues such as symptoms control are common to both palliative care and end-of-life care, but there are also problems which are specific to the sense of approaching death. These include a heightened sense of spiritual need, profound fear, and the specific need of those who are facing bereavement. So we must need to appreciate all these things, especially euthanasia that will be in particular in Western population, and of course is not feasible in Muslim communities. Physician assisted suicide, even according to certain religion, is allowed, but in Muslim community is strictly prohibited. Living will, of course, everybody have the right to just sign a living will and just plan, or whatever he likes, he can just write down in his will. Bereavement to the affecting family, spirituality and support to allow death at home, and the problem of medicalization of death are main concern as end-of-life care. Thank you very much for your attention. So if you have any question in your mind, you can just comment in comment section below.